Well, welcome everybody. Thank you for joining us today at this satellite symposium on relapsed refractory primary CNS lymphoma. I'm very excited to open this session and very excited to welcome you guys to ASH 2025 too. Before we get started though, I did want to highlight a couple of just housekeeping items. First, take a look at that QR code that you see on the screen there. That will allow you to access slides and also ask questions. There's no microphones for those in the room, and so if you want to ask a question, please log in through the QR code and then ask it there, and it will come across our eyes here. Please also use this to participate in polling too. For those live in attendance, the Wi-Fi network and password are listed right there too. So please feel free to take a second or so to join as we begin our program. Without any further induction, welcome to Targeted Therapies in Relapsed Refractory Primary CNS Lymphoma. My name is Chris D'Angelo. I'm an assistant professor at the University of Nebraska Medical Center, and I'm joined today with Dr. Ayushi Chauhan, a lymphoma specialist at the MD Anderson Cancer Center, and then Dr. Sumral, a neuro-oncologist at the Levine Cancer Institute in North Carolina. Thank you both for joining me today. So basically, to just go through our agenda very briefly here, I'm going to kind of introduce some of the key thoughts in this session here before turning it over to Dr. Chauhan, who will highlight the treatment landscape and challenges in primary CNS lymphoma. Dr. Sumral will follow up with all of our solutions to these challenges in primary CNS lymphoma. And following that, it'll be an opportunity for a panel discussion that will be when we can start our question sessions as well. And then, before we wrap up, we'll have another opportunity to speak together, to go through a Q&A, and I'll spend a couple of slides just highlighting some of the interesting abstracts in CNS lymphoma for anyone that's looking for content at this meeting. So I think for everybody at this session, just to kind of set the stage here, I think we're all pretty well aware that the prognosis in relapsed refractory primary CNS lymphoma needs to be improved, particularly in those that experience early relapse or are refractory. Overall survival is measured in single months. And certainly an opportunity here to think about ways and strategies that we can improve on this. And indeed, it is a challenge, and in trying to distill this to a couple of three unique challenges or problems, we tried to conceptualize this in three simple ways, looking at this as a pathway problem, trying to understand how the molecular and biological drivers of this disease influence its progression, influence its resistance, and how we can overcome those pathways and design targeted therapies using them even in combination. The frailty problem here too. So it's not just a challenge of identifying novel therapies that can work here. We also need to make sure they fit for our patients. And then finally, on top of all of that, there's the population problem, or understanding how we can approach this in what's truly a rare disease. And so to just go into a little bit more detail on this, what this cartoon is meant to demonstrate is the tumor microenvironment within the primary CNS space, as well as some of the pathways that cancer B cell uses in driving its pathogenesis. So we have some unique challenges here, some of it just penetrating the blood-brain barrier to begin with. Then how we are able to access a complicated tumor microenvironment with our therapies. And then, as this cartoon shows on the top here, how we can use some of these signaling pathways that come between B cell receptor signaling, TLR signaling, and then immune evasion that is a known issue that comes with this disease. Next, and very importantly as well, is the frailty problem. So the majority of our patients with primary CNS lymphoma are older adults, and they come with comorbidities. The other issue that comes with treating primary CNS lymphoma is the disease site itself. Having cancer in this space puts patients at risk of all kinds of different side effects from the disease or the therapies that we use that can impact their ability to live their lives and enjoy a good quality of life. And this cartoon on the left just highlights the multi-different dimensions that can accumulate and drive frailty. And you can understand here certainly how CNS lymphoma can impact all of those uniquely, particularly with respect to mood, cognition, mobility, and even social vulnerability too. It's a disease that certainly can affect more than one function here. This cartoon on the right, I think, captures this frail problem here. You can see on the left here, if you look at that first part of the cartoon, These patients have a little bit more springs in them, and when you add stress to them, fit patients have a little bit more resilience to that. They can shoulder those stresses a little bit more. Frail patients, if you can see there, their adaptive capacity in that cartoon is just a little bit lower than fit patients, and we know what that looks like in clinic. Those are our patients that walk in maybe 3 months before all this happened. They were golfing 18 holes a day or so, 5 times a week. The problem with them is they don't necessarily look frail at first. It's as soon as those stresses come, either the disease or potentially the disease and then the treatments that start to overwhelm them. And it's because of that loss of adaptive capacity. So I love that kind of spring cartoon that they show here, where these extra stressors really start to produce that frail patient. And that's what we can observe in clinic too when we ask ourselves, where this frailty came from. It was there, and it really just showed it when they had to shoulder some extra loads of a disease and side effects from therapies. Finally, the population problem. So this is a rare disease, and the only way we're going to move forward on our pathway and frailty problems here is working together, is recognizing that this is a rare disease. 4% of all primary CNS tumors and 5% of all extranodal lymphomas, depending on which pie you'd like to place primary CNS lymphoma into. And this is a disease that is managed expertly by both neuro-oncology and hematology lymphoma specialists. And they all bring unique expertise to this disease. And these cartoons are meant to highlight this a little bit. As a disclosure, there was AI that was used to generate this talk, and only for this cartoon here. We asked Copilot to make a cartoon of CAR T-cell therapy going in there and treating the disease, and you can see it brings the energy that we want to bring to this disease of that CAR kind of ramming in there and delivering its damage. On the right is a cartoon taken from a really interesting study in glioblastoma that has a lot of different sets to it and is able to generate a very rich data set. This is a trial that is very collaboratively built in mind, and it crosses different cancer centers in treating a really challenging disease and has a lot of different steps to it that generate a rich data set. And this neuro-oncology approach to it, I think, is a great lesson in understanding maybe how we can collaborate here too. These are the types of studies that we need to answer not one question with one clinical trial, but one clinical trial, many clinical questions, ideally. And so to just kind of summarize on those things, we know the overall problem here is dealing with a disease that has really low overall response rates and median overall survival, particularly in the relapsed refractory setting. Our standards of care don't get us as far as we need to be, in part from challenges from the blood-brain barrier, the microenvironment, but also frailty, the cumulative neurotoxicity that can come, and the performance status at baseline or immediately after treatment. So novel therapies matter here because that's probably the way that we're going to move forward, not with a canon of chemotherapy or radiation, not that those don't have their role, but really with scalpel-based approaches that target different biological signaling pathways and do this in a way that penetrate the CNS and do this in a way, ideally, with combination therapies in the future and in a way that is safe and effective and meets our patients, our older patients and our frail patients more than halfway. Oral regimens, outpatient regimens, things that are rationally designed to lower toxicities. And so it's truly a collaboration across different expertises, and neuro-oncology brings a lot of expertise with respect to truly understanding those agents that penetrate into the blood-brain barrier, understanding how the disease in specific anatomic sites can produce specific symptoms. Hematologists bring lymphoma biology understanding and agents that work in that space and some of the cellular therapies that work in systemic lymphomas. And truly how we can meet together gives us a best sense of how to approach this disease, meeting those pathway, population, and frailty problems. And so with that in mind, I'd like to turn this over to Dr. Chauhan, who will take us through the treatment landscape and challenges in primary CNS lymphoma.
Thank you, Dr. D'Angelo. So we'll be talking about the treatment landscape and challenges in primary CNS lymphoma. I'm one of the lymphoma attendings at MD Anderson with a subspecialty in CNS lymphomas. So brief background, which Dr. D'Angelo has already discussed, that it is a subtype of diffuse large B-cell lymphoma, and I'll show you a pie chart of why I just mentioned DLBCL. characterized by exclusive confinement to the central nervous system and the vitreoretinal space. Of course, it's a rare disease, as has been iterated before. Only 1,500 new cases per year in the United States. And barring immunodeficiency, it will be a disease of older adults. The incidence in those patients who are older than 70 years of age is 10 times higher than the general population, and the overall survival has not improved in this age group, so highlighting the frailty and also the population problem together that Dr. D'Angelo mentioned. This shows you the incidence trends of primary CNS lymphoma. The blip that we see in sort of the 1980s, 1990s was of course during the heights of the HIV/AIDS epidemic, but then subsequently it's really a disease of older adults. And the reason why I mentioned DLBCL is because what we will see in clinic will predominantly be diffuse large B-cell lymphoma. And of course, as your practice is enriched for CNS lymphomas, you'll have the scattered marginal zones or the lymphoplasmacytic lymphomas, the Bing-Neals in the brain, but predominantly it will be DLBCL, which is craniospinal primary CNS lymphoma. And we're not talking about, of course, orbital and ocular disease. Risk factors for primary CNS lymphoma, of course, immunodeficiency and really, in a way, immune senescence and immunoincompetence, which happens with older patients. So HIV, immunodeficiency associated, and we are saying older immunocompetent adults, but of course, we are not talking physiological immunocompetence here. The pathogenesis of primary CNS lymphoma, although there are a lot of words on the slide, but frankly, it is still an area of, with a lot of unknowns. We don't really know whether this is a cell that starts systemically and then undergoes CNS tropism subsequently and then finds its immune niche in the brain versus a lymphocyte that is trafficked already in the CNS craniospinal system that develops mechanisms to basically evade the immune system. So we don't know whether it has a CNS or a systemic source, or whether it's a brain resident cell that undergoes transformation into a malignant lymphoma cell, or whether there's a peripheral transformation with selective brain homing. So these are the pathogenetic mechanisms that are still unknown in primary CNS lymphoma, despite the fact that we do know the downstream signaling pathways. We do not know the putative origin of what happened to let it be trafficked to the CNS. The immunophenotype of primary CNS lymphoma, and for those of you who are perhaps hematologists and also see aggressive lymphomas, it will be what we call the non-germinal center phenotype of diffuse large B-cell lymphoma. And if you are familiar with the molecular clusterings of diffuse large B-cell lymphoma, this would be something that would fall in what is called the MCD phenotype of activated B-cell diffuse large B-cell lymphomas. So it will be a post-germinal center cell. Even though CD10 is expressed in a minority of cases, predominantly it will be an activated B-cell phenotype, late germinal center cell with an arrest just before the plasma cell differentiation. BCL6 will be positive in majority of cases, plasma cell markers will be negative, B-cell markers will be positive, and of course MUM1, which is a post-germinal center, non-germinal center marker, will be positive. And therein comes the molecular landscape of primary CNS lymphoma. So, and Dr. Sumrall will talk more about how we target. Dr. D'Angelo has already laid some foundation of it, but dominantly, the way I would like you to think about it, it's characterized by, in a way, constitutive NF-kappa B signaling that comes downstream from the B-cell receptor pathway, right? So all of the targets that Dr. Sumrall will subsequently discuss and what has briefly been mentioned will be targeting to a certain degree the NF-kappa B pathway, whether upstream, downstream, or sort of middle, right? So you're targeting CD79, you're targeting BTK, you're targeting SYK, you're targeting immunomodulators, or of course you're adding like, immune escape pathways. Just briefly, EBV-associated primary CNS lymphoma will be a distinct entity which will have a more immune-evasive phenotype. So like intact HLA, it's rarely ABC, doesn't usually have MYD88, CD79B, PIM1. However, might be more sensitive than non-EBV-associated primary CNS lymphoma to checkpoint inhibitors. Diagnostic challenges briefly, of course, the general challenges for any CNS tumor, especially when you're dealing with an older population, is other confounding medical comorbidities, particularly dementia, particularly just acute metabolic encephalopathy. The neurological symptoms can be nonspecific. The lesions in primary CNS lymphoma typically tend to be deep brain parenchymal lesions. So, of course, biopsies are challenging, and there may not be much CSF shedding for us to use a lumbar puncture as a dominant or as a reliable source of diagnosis. Many patients may already have been started on steroids because of clinical extremis. So by the time they get to you, either getting them off steroids to get a diagnosis or getting a diagnosis right off the bat will be challenging. A neurosurgical data set showed that there is even among brain tumors, primary CNS lymphoma has almost a double, time to diagnosis compared to other tumors like glioblastoma. But of course, glioblastoma will be more vascular, necrotic, and has higher vasogenic edema, perhaps. Cognitive presentation challenges can also happen because you can have what is called a lymphomatosis cerebri variant of primary CNS lymphoma, where patients are presenting with a gradual neurological decline, which is often confused with dementia or other neurodegenerative conditions, and that can be a diagnostic challenge. Early diagnosis and time to treatment. So like in DLBCL, most relapses do occur within the first 1 to 2 years. However, unlike DLBCL, relapses can happen much later, and they're typically clonally related to the original relapse, which is unlike what you see in systemic DLBCL. And median time from symptom onset to diagnosis is long, and time does matter because diagnostic delay is associated with inferior survival in primary CNS lymphoma, predominantly due to neurological compromise. And this is just a figure showing the diagnosis or treatment interval in primary CNS lymphoma. Again, a little variation from DLBCL because standard of care for primary CNS lymphoma, this was meant to be this booming graphic. There is no standard, and I'll show you why. You do have treatment options. We all know methotrexate works, cytarabine works. Of course, in relapse refractory disease, you'll try to use those existing therapies, and you'll try to consolidate those who are able with an auto transplant or use radiation. However, with the older patient population, you know that these modalities will be very challenging. And of course, we need the increasing incorporation of immunomodulators and novel targeted therapies primarily for this reason. Again, just showing a brief graphic for NCCN recommendations for primary CNS lymphoma, which is really just a mixed bucket laundry basket. You can consider whatever, but these are recommendations, but not really a guidance, so to speak. So I don't think, these slides were meant to just highlight that. And look at the relapse refractory bucket. It's consider. So you can consider all of it, but how do you sequence, right? How do you pick one? How do you target? And that will be the topic of our discussion later too. And just key clinical trials in relapse refractory primary CNS lymphoma. The slide is just here for your perusal, but Dr. Samral will be discussing all these data shortly. So without ado, I will let Dr. Samral go and discuss the novel targeted therapies.
Thanks. One could think this is very short, but it's not. And I was sharing with my friends earlier, 15 years ago, this would be very short. We would just say methotrexate or Rituxan. So it's a delight to be able to talk about options for these patients. This is such a multidisciplinary based condition, as we mentioned. And so because of the nature of this condition and the different types of physicians who treat it, you can tell that this management will be highly individualized for the patient. So some of our key considerations will include what therapies did the patient receive before? Did they tolerate those therapies? Were those therapies effective for them? The patient's performance status and fitness. With our patients who are dealing with brain, spinal cord issues, it's different than those who have systemic illness. And so oftentimes these patients have been disabled cognitively, or they may have memory impairment, they may have functional and physical impairment, and of course that all needs to be taken into consideration. The disease characteristics and the burden of disease, and then of course we've highlighted on previous slides the time to relapse from initial therapy. And as we just heard, we may have a relapse in 1 to 2 years or much further down the road. And I've seen all of that in my clinical practice. And our treatment options are very diverse. When we look at the NCCN guidelines, or if you talk to a friend in another center, you will find that people approach this dilemma in multiple different ways. And so we have our systemic chemo, our good old-fashioned cell killers that go in. We have transplant for those who may have chemosensitive disease and are fit for this. Radiation, boy, we have had, this has come in style and out of style. So whole brain radiation, or SRS, is being offered for some individuals. And then targeted therapies. That's where we're really very excited about what the current status is and what the future holds. What's a lymphoma talk without mentioning CAR-T? So CAR-T is out there and of course is an emerging option for this recurrent relapse refractory disease process. So I feel as if we have really hammered on this unmet need, and if you're attending this in person or virtually, odds are you've encountered a patient with this disease that you've wanted to help. And so there's a significant unmet need. As a neuro-oncologist, I'm also a hematologist-oncologist. I feel like I'm always shouting to the crowd that our patients with brain and nervous system tumors need more attention. And highlighting the fact that we're here even talking about this at ASH is a really big deal. Because there is this high unmet need. There are no approved therapies in this setting. We have so many drugs for other conditions, for systemic lymphoma, for multiple myeloma. We have no approved therapies in this category, and our salvage treatment options are limited. We listed several of them, but they all have, side effects and so forth. And the relapse rates, we really don't even have a pinpoint number. Our range, depending on where you look in the medical literature, can range from 33 to 60%. And so oftentimes when we meet patients, we'll tell them to expect recurrence at some point. But it is a little more nuanced or different than our primary glioma patients, for example. We think of this condition as having a poor prognosis when we put on our hem-onc hat. When we put on our neuro-onc hat, we get a little more excited about it because these patients do better than some of the others that we're seeing in clinic. And outcomes are literally improving month by month as we have introduction of new therapies and clinical trial offerings. The disease biology, we understand somewhat, not fully, but we know that diffuse large B cell is the predominant type that we see. We know that there's aberrant BCR signaling that activates the NF-kappa B pathway, and this drives that malignant B cell survival and proliferation that we see under the microscope, also clinically, and ultimately on radiographic images. So let's talk about BTK inhibitors as a monotherapy. For a long time, people have been using these medicines, the more that we've learned about this BCR signaling pathway as demonstrated here. And we know that BTK regulates the BCR signaling. Inhibiting BTK suppresses NF-kappa B activation, thus preventing downstream activation of survival and proliferation signals. And the great thing here is these drugs get into the nervous system. Anytime we're thinking about something that is in the brain, in the spinal cord, or in the fluid, we have to think about how does that get in. So this makes it suitable for CNS disease. And I would also pause because as we consider all of these medicines, anytime we have a malignant process in the nervous system, the presence of that cancer also steroids, also potentially surgery and or radiation. All of those affect the blood-brain barrier as well. And a lot of times we think of the blood-brain barrier as this brick wall, when really it's more of a Swiss cheese kind of constitution there. So ibrutinib in this setting. So we're going to reference some data by Christian Grommes, and so this was a small study but very important, this phase 1/2. And so the response rate was 74%, but there were 12 CRs. And so this was a very big deal in our space because it demonstrated that in this relapse setting you could offer therapy to individuals that was fairly well tolerated. PFS on average or on median was 4.5, and if you'll notice, the median overall survival, the upper limit has not yet been reached, but that is currently 25.4 months, so longer than 2 years, which is very impressive. Safety data, we had primary CNS patients as well as secondary, and it was demonstrated that this therapy was well tolerated and adverse events were manageable. There were no treatment-related deaths, which is always a plus. We love to see that. And the NCCN guidelines incorporated ibrutinib as monotherapy or in combination with methotrexate and rituximab. And this is important because I can remember trying to offer this therapy to individuals and insurance companies rejecting it because we didn't have data. So anytime we can help to get the drug to the patient, it's not enough just to have it in theory, but to be able to actually offer it to them. Shifting a little bit, we'll talk about the phase 2 prospect trial, and this involves tirabrutinib in the recurrent and relapse setting. And you'll notice these are the key eligibility criteria for prospect: adults 18 and up, a good performance status, a measurable lesion with a minimum diameter of 1 centimeter. This is particularly important because sometimes your patient will have had a surgery to resect because you're not sure if it's recurrent disease or something else. So you must have a 1 centimeter lesion, recurrence or refractory setting, at least one prior methotrexate-based therapy, and a life expectancy of 3 months or more. And those individuals took oral tirabrutinib at the dose mentioned here. And then the endpoints you can see include response rate per IPCG, and then secondary and exploratory as noted here. Looking at the patient characteristics, you'll note that this includes 48 people. The ages range from the mid-30s up until 87, so it covers a large swath of population there, and we mentioned how our older adults need to be included in this work as well. Both ECOG performance status and KPS were included here. And one thing that I'll mention here is sometimes when these patients present initially or at time of recurrence, they've had a significant dip in their performance status. And one of the fun things, maybe not fun, but fun for neuro-onc about CNS lymphoma is that you can make these patients better. So they're not stuck in that performance status. So I think it's important that we pause and think about eligibility criteria in these settings, and this one was very thoughtfully done. These individuals had prior treatment for primary disease as listed here. Everyone had exposure to methotrexate, almost everyone had rituximab, some had cytarabine, some had radiation, and some had transplant. And then you move down to the status at the most recent treatment where you had about 48% with refractory, 46% relapsed, and then an amount of unknown there. And you'll notice for prior treatments for disease, there were quite a few first line, but we also had second and third line or greater included as well. So truly refractory disease in this setting. And here is the efficacy data. So we look at the chart on the left with our primary endpoint of overall response rate, and you can see that there were some CRs and unconfirmed CRs, and then you also had some PRs here. Skipping over to the opposite side, is this a durable response? And we had a median duration of response to be about 9.3 months for these individuals. And so as we look at the outcomes, the PFS is estimated at about 6 months, and then overall survival has not yet been reached, which when we're talking about any neurologic cancer, it's truly a delight when you have that not reached overall survival. How about the safety? So treatment-related adverse events are listed here. We have any grade and then grade 3 or greater. And you'll notice under the grade 3 or more, there were some who had a dose interruption. There were 0 under dose reduction for the grade 3 or more. Study withdrawal, there was 1 patient. Serious effects, you can see for 5, and then there were no fatal treatment-related effects. Cardiac events, the incidence was under 10%, and if they occurred, they were grade 1 or 2. And you'll note that the most frequent adverse events were fall, fatigue, anemia, lymphopenia, headache, diarrhea, and pruritus. So interestingly enough, this tirabrutinib has been approved for relapsed refractory CNS lymphoma in Japan, Korea, and Taiwan, and the results will hopefully inform decisions about approval here in the US and also in Europe. This is a really interesting data set, and this was presented at our SNO meeting. SNO is the Society for Neuro-Oncology. We just had our meeting a few weeks ago, and this is the Rosetta study, which was real-world effectiveness of the use of tirabrutinib in Japanese patients with recurrent refractory disease. And so the patients included, the take-home message here, the individuals who had 1 prior treatment showed a longer progression-free survival compared to those who had multiple treatments, and that makes sense to us. The performance status varied quite a bit, and I mentioned earlier that when these patients present to you initially or at recurrence, they may really be very ill. And so as they recorded data here, they treated all comers. They treated people who were in dire straits. And you can notice the difference here. The better the performance status, so 50 and up, the patients did better. And the treatment interval, as we have illustrated earlier too, this bears true here as well. If you had a year or longer of an interval between your previous treatment and starting tirabrutinib, you had a longer PFS. And the median data here, 15.6 versus 11 months. So in summary, prolonged PFS with tirabrutinib went with 1 prior treatment, better baseline performance status, and longer interval since previous treatment. So we talked about monotherapy, and in hematology and oncology, we love to combine things together. In neuro-oncology, we love it too. We'll put a couple of medicines in a basket, shake them up, and go for it, right? And so this is a busy slide, but I think it's important because when we first started treating this disease years ago, we didn't have additional options. And now to see a slide like this with different medications being tried and a very thoughtful approach is really, really exciting. So we'll start on the left with a phase 1b from Dr. Gramas and his team. There were 15 patients. A response rate of 80% was noted, and I always pull out, you have some of these exceptional responders to some of these treatments, and so CR rate of 53% there. The median PFS was 9, and again, median overall survival not yet reached, which is exciting to hear, and a 1-year survival of 71%, well tolerated, and then quite a few of these patients went on to receive ibrutinib maintenance. Also a very durable response with just over a year. And so this was a very thoughtful, well-planned study. Small number of patients. The next one was a phase 1b with a little bit more of a patient population, and this was ibrutinib plus len plus rituximab. And you'll note this also had a high response rate of 80% and 44% with a CR. If we separate out the primary CNS lymphomas, which is pertinent to this discussion today, you'll see that that response rate bumped up a little bit to 89%. The PFS was lower in this group, 4.3, but the median overall survival also not yet reached.
And then duration of response was shorter in this group, but also a well-tolerated regimen. And I think tolerability is really important in this patient population, especially as we think about those older, perhaps frail individuals too. Next, we have a phase 2 study, including ibrutinib plus nivo, and an overall response rate just shy of 80% in that group, the CR rate of 50%, the median PFS was just over 6 months, and a median overall survival of 21 months, and 3 remissions of greater than 2 years were noted, or 3 responses greater than 2 years. Well tolerated, 2 patients stopped treatment due to fatigue. And then lastly, another phase 1b, ibrutinib and copanlisib in primary disease. And so this had a little bit of a lower response rate and a PFS of 3 months. And interestingly enough, there was a drug-drug interaction to where you had undetectable ibrutinib levels with concurrent dosing. Quite a few toxicities here, grade 3 and 4, including 1 fatal infection. So again, as we move through these different combinations, we're learning more as we look at that data. I love this slide and talking about it because, true story, I was in clinic with a patient yesterday and my pharmacist came in and said, "Hey, what do you know about the newer agents for CNS lymphoma?" And I said, "Ooh, I'm so glad you asked." So very relevant clinically. And so here we have some information on acalabrutinib, which was examined in a phase 1 study combined with durva. There were quite a few adverse effects or adverse events in this patient population, a lower response rate than what we saw on that other slide just previously. Zanubrutinib was evaluated in a pilot trial when added to Rituxan and methotrexate in newly diagnosed disease with a response rate of nearly 67% and a pretty significant amount of adverse events, but again, we have to mitigate those, and it's certainly a very interesting agent. And orelabrutinib, which was evaluated in a phase 2 study, added to rituximab and high-dose methotrexate for newly diagnosed with a response rate of 90%. And then the A's that were reported were neutropenia, lymphocytopenia, and infections. And I think we'll be hearing much more about these agents in the use of the nervous system to come. We'll move to another mechanism here with IRAK4 inhibition. And so the mechanism of action, which is displayed here in this cartoon, the exceptional Dr. Gramas, who I actually met at SNO. I have not met him in real life. He's lovely. He's done such important work here, he and his team. The mechanism of action here is IRAK4 is highly expressed in the tumor microenvironment with primary CNS lymphoma. It forms a complex with MYD88, and it triggers NF-kappa B overactivation that promotes tumor growth. And MYD88 mutations occur in about 70% of primary CNS lymphoma cases, so it's a critical therapeutic target. I have a newly diagnosed patient that we just sent off NGS who had a MYD88. So there's a phase 1/2 TAKE-AIM lymphoma trial, and this uses this one is really hard to say.
We just call it Emma.
Yeah, I was going to say, I'm just going to call it Emma. Emavusertib. I feel like we should have a prize for someone to pronounce some of these drugs. We'll hand it out to you. Plus ibrutinib and relapsed recurrent disease. And you'll note that parts A1 and A2 have been completed, and that involved multiple NHL subtypes. There was a monotherapy arm and the combination arm. And currently enrolling, we have a part B and a part C here. And so we have primary CNS lymphoma in those who are BTK inhibitor experienced, and then those who are naive. So the single arm design for the combination therapy in the experienced patients was designed in a single arm manner, hopefully to get that drug pushed through quickly. And then part C had a randomized design as illustrated here with monotherapy, or combination therapy. The baseline characteristics for patients included here, median age 63, and again, we do see some patients up into the 80s here. There were 16 male patients in this population. The median prior anti-cancer therapy was 2, with a very broad range of 1 to 5. And then almost 80% of the patients had prior BTK inhibitor exposure. And I can tell you clinically, we're so enthusiastic about using the class of BTK inhibition here. It is really important to have options for those who have had progression of disease in that setting. So in this combination for Take-Aim lymphoma trial, the results here are as follows, and Dr. Lakshmi Nayak presented this data at SNO last month. And so there were grade 3 and higher adverse events reported in 11 patients. There were neutropenia, or neutropenia was found in 5. Amylase and lipase were increased, and there was some leukopenia. And of note, the majority of these grade 3 and higher adverse events were reversible and manageable. The efficacy. So those who were BTK inhibitor experienced, and again, that super refractory population, there was a 36.8% response rate. There were 5 CRs, which is exciting to think about, and 2 PRs. And the longest response for a patient is ongoing at just over 26 months. I love how in neuro-oncology we'll count every single day in those responses, so 26.2. And those who were naive to BTK inhibitors, there were 5 of those patients, a 100% response rate with 1 CR and 4 PRs. And that patient with a CR is still going at just past 18 months. And then overall, you can see the data for 50% response rate with 6 CRs and 6 PRs. So again, encouraging, especially in this heavily pre-treated or population of patients. So I used to cry sour grapes in neuro-oncology because I felt like all of the cool kids and their cool diseases were getting tumor profiling and mutation classification ahead of us. Our friends with lymphoma, our friends with lung cancer. And so we've really had a period of catching up in neuro-oncology to do, not just for glioma, but also in primary CNS lymphoma setting. And so this highlights how the trials are changing. We're now including all of this information in the CNS lymphoma trials. And so the levels of the drug in the CSF with EMA were significantly higher in those who received the 200 BID dosing regimen. And we learned that plasma concentrations peaked 2 to 3 hours after the dosing. And this is what's so fascinating to me. There were targeted sequencing done, which revealed distinct mutational profiles between those who responded and those who didn't respond. And so responders had a higher prevalence of mutations in TP53, GANT12, WT1, and BMPR1A. And then those who didn't respond had different mutation patterns. So we're finally getting to the level in this disease where we're thinking about what the disease looked like at diagnosis and at recurrence, and then also for those who respond versus are not responding to these therapies. Next, we'll talk about R2I combination therapy. And so this is when we include rituximab and then Revlimid or lenalidomide, and then the I for ibrutinib. So the rationale here for combination is that both primary and secondary CNS lymphoma, as we have illustrated, these patients do not do well, especially in this secondary setting, and the individual agents that we've talked about have limited activity. And so the preliminary clinical data here, there were 10 patients with primary or secondary disease, a median of 2 prior lines of therapy. There were 4 responses, 40% CR, 80% ORR, and the 1-year overall survival was 56%, a 1-year PFS of almost 39%. And this has an interesting niche area as it could serve as an effective bridge to those who may move on to cellular therapy with transplant or CAR T. There were no deaths or no discontinuations due to toxicity, and it seems that the regimen has been well tolerated by the patients who received it. On to CAR T, where everyone in this room knows more about it than me. CAR T is so thrilling to learn about and to watch how it is transforming how we treat these conditions. And so to offer it in the CNS lymphoma setting is pretty exciting. So as many of you are aware, you have autologous T cells engineered to express chimeric antigen receptors. They target CD19 antigen on the malignant B cells, and they induce direct cytotoxicity, just like that minivan that was driving through those cells. I thought it was extra cute that it was a minivan and not like a Porsche, you know. They have excellent CNS penetration, which we know, and the potential for durable, long-lasting remissions is really what we're after here. So let's review some of the data that we have here. So the clinical efficacy, the CR rates, 40 to 65% in heavily pretreated patients. The one-year PFS rates have a broad range of 35 to 60%, and median overall survival ranges from 19 to 21 months. And key here is that there were responses observed even in patients who'd had multiple prior therapies, lots of exposure to other treatment types. Now to the safety profile. And in considering this, you know, these patients have had CNS lymphoma that has returned. They may already have significant neurologic issues, so we really have to be thoughtful here. The rate of CRS was 70 to 92% for any grade, and then 0 to 21% for the 3 and 4 grades. For ICANS, we had 36 to 68% of any grade, and then about 4.5 to 29% for the higher grade toxicity. And these neurotoxicity rates are similar to those seen with systemic diffuse large B-cell treatment. And it's thought that they're generally well tolerated despite the CNS involvement here. So what is our treatment position here? Well, it varies depending on who you talk to in the field. So technically this is off-label, but in neuro-oncology, almost everything is off-label. That does not dissuade us. It is not formally approved for primary CNS lymphoma. Most experts would agree that this is typically used in at least the third-line setting after relapse or recurrence to transplant. And then the products are consistent with those that we know of that are available for lymphoma. And bridging therapy used in 70 to 96% of patients to control disease before infusion. I think that's an important point. And also thinking about one of the slides that we mentioned earlier, the R2I. You can't just leave these patients alone because this lymphoma will just take off very quickly. I think this slide gives us a lot to think about. More than so many diseases that we care for, there is truly no one-size-fits-all approach, and you have to individualize based on the patient in front of you, clinically, radiographically, frailty. You have to consider what therapies they've had in the past. You don't want to repeat a failed approach. You also want to think, you know, is this the patient that you treated with methotrexate who almost didn't make it out of the hospital? You know, how well did they tolerate this therapy? You can evaluate the patient for CAR T cell therapy, especially for early relapse or refractory disease. This is where those of us wearing our neuro-oncology hats run across the hall and chat with our hematology colleagues. It's a very collaborative approach, it should be. Combination strategies make a lot of good sense, and they may enhance the efficacy offered here. And of course, we always want to pursue clinical trials where we can, if it makes sense for the patient and it's feasible to do. So targeted therapies have transformed this treatment landscape for sure. We have improved outcomes and multiple options that we couldn't have dreamed of 20 years ago. The BTK inhibitors get into the CNS. They have meaningful responses. You have to be cautious and monitor, just like with any treatment that we offer. CAR T, of course, is promising. And I think the biggest message here is multidisciplinary collaboration. So involving your neurosurgeon, your radiation oncologist, your neuro-onc, your hematologist, your pathologist, and others. Geriatric oncology is a great add-in here as well. And it's truly collaborative and fun when you can work with your other colleagues to help these patients. And I'll hand it back over.
Perfect. So I think that was a really wonderful introduction to this problem here, the challenges that come along with it, and really some emerging solutions that are starting to be developed here. I would say attending sessions like this and seeing the new data that are coming out here, one of the big messages that's coming to me in this landscape, and I think you pointed at this a little bit too, is hope. I think 10 years ago you described there was methotrexate and rituximab, and look at all the different data that is coming in now in the last couple of years or so. I think that speaks to the interest that is being grown in this disease, and it speaks to the population problem here a little bit more too. I think as we're recognizing how we navigate the challenges of a rare disease, one of the things that's really important here is support from across different angles, having patient interest groups advocating for patients, finding clinical trials, having centers working together and sharing their knowledge, and also having stakeholders interested in developing novel agents to treat this disease. Without those things, without that interest from all those different dimensions, we wouldn't be able to move forward with these agents in the clinic. And it's very exciting to have some new agents and sponsors that are interested in developing these. And so with that in mind, as we pivot into some of our discussion sections here, this is just another comment to, and another moment to please join on the QR code and ask us questions. That's the main way for both the virtual and the in-person participants to engage. And so we have actually luckily had a few questions come in since we've started the talk here. So I'll lead off with a question about blood-brain barrier penetration. So are there any data regarding CNS lesions and therapies that can disrupt the barrier and increase the permeability of certain drugs? And then kind of a follow-up question, what's the location of are there lesions in the brain that might change the permeability of a drug with respect to the blood-brain barrier?
So I'll take a stab at it. I think that's an excellent question. So while we may not have much data for actually combining specific drugs to disrupt the blood-brain barrier, there are enough data in CNS lymphomas and CNS leukemias to know that the very presence of a CNS lesion disrupts the blood-brain barrier. Now, and the reason why I say this is, for example, in acute lymphoblastic leukemia with brain penetration, blinatumomab works. Right, it's a big molecule. It's a bispecific. Right, theoretically, it should never be able to penetrate the blood-brain barrier. But the T cell engagement and the disrupted blood-brain barrier, simply by the presence of a CNS lesion, leads to T cell penetration. Now we have data coming out of the lymphoma bispecific engagers, particularly glofitamab, showing CNS penetration, which from just a molecule Dalton weight standpoint should never be able to happen. But really, it's a physiological disrupted blood-brain barrier and the T cells that can perhaps engage with the microglial environment of the CNS system that will lead to these drugs penetrating.
Mm-hmm. So I think this is one of those areas where, to put it bluntly, we're not very smart because rituximab shouldn't get in. I remember I was a fellow and I got into a little bit of an argument with an attending about this because clearly it gets in and maybe it shouldn't, but it does. And one of the things that we talk about in neuro-oncology is that we think of the barrier as this wall, this fortress, when it's really not. And then just the presence of the cancer disrupts it. And we're starting to learn that the presence of something like a glioma or brain mets, that's a different disruptor than a lymphoma. So the different processes disrupt differently. Now, the methods of disrupting the barrier, boy, this is another one of those things that will come in and out of style. You know, it's like short genes or long genes or tight genes. You know, every few years something resurfaces. And so right now there's some enthusiasm for ultrasound-based therapies to disrupt the barrier, microbubbles. There are multiple devices that are being studied. And I will say, attending our SNO annual meeting, there was more information available, posters and abstracts about blood-brain barrier disruption. And so I'm really interested to see if that bears fruit. In the past, it is not. And then I would just add, radiation and steroids also affect that barrier as well.
I think those are wonderful summaries, and I think the short answer is we should be investigating all of the above with respect to trying to find better outcomes for this. So certainly interested in the disease space and every kind of different way that we can approach this. Your point about the bispecific antibodies is interesting too, and especially building on that initial experience with rituximab. We don't really, at least at face value, understood exactly why that works, and it probably does speak to more micro disruptions that are happening here that allow these to get in here. There was another question that was asking about the role of bispecific antibodies. I think until we know more specifically about this, it's a great example of using an effective therapy up front, at least maybe to start. Now, we don't have the data yet for this, but I could certainly see a rationale of using it early on and then maybe stopping it over time as the disease gets better. The blood-brain barrier actually becomes a little bit stronger, unfortunately. And this, we think of CNS lymphoma as a whole brain disease. So there are certainly regions that get a little bit farther out that don't have that same penetration. So I could envision this in the future as a sort of initiation therapy and then kind of letting the more CNS penetrating molecules take over.
And yeah, and to that point, we'll probably have some more data on the delivery mechanisms too. So one of our lymphoma colleagues, Dr. Tanya Siddiqui, is conducting a trial of intrathecal CAR T-cell therapy, right? So if, those data come along and mature and we compare that to systemic CAR T, perhaps we know whether the delivery mechanism can also overcome that. Some researchers at MD Anderson and different solid tumors are looking into exosomes as another delivery mechanism, and perhaps those can be explored as targets in CNS lymphomas in the future.
Yeah, those are wonderful explanations. All right, so moving on to a couple of trial-specific questions here. In the PROSPECT trial, were patients with lesions less than 1 centimeter enrolled, and if so, were they studied in their evaluation, particularly if they had any lymphoma cells in the CSF?
They were excluded. I have additional experience there because I tried really hard to put someone on who was a 0.9, and I had this very difficult discussion of, do we let it grow or do we, what do we do here? And this is also an area where I always encourage my colleagues to look at your own images and measure your own findings there, because there is quite a bit of diversity in the way that neuroradiologists interpret scans, especially in this space.
I think that's a great point. And I know as the IPCG is developing new criteria to suggest to sponsors that are writing clinical trials, we are looking at this question of measurable disease. Every study, not unique to CNS lymphoma, have measurable disease criteria so that you can understand it's especially important in early phase studies and get a good sense of response rates and stuff. Now, that being said, I do think there's probably some wiggle room with respect to that, and even just massaging at the edges here could be enough to get more people on and not restrict this, speaking to that population problem that can come from this.
Well, and I would also add, this is where communication with your surgeons is really important, especially in the newly diagnosed setting. So if you are in a tumor board, which most of our cases that we think could be lymphoma come through, we have that discussion of, is the patient on steroids because he may have low yield from surgery? Also, they're going after brain mets and gliomas oftentimes where they want to get all of the enhancing material out. In a lymphoma situation, that's not the same goal. So having that ongoing conversation with them, and in fact, the way that we're approaching lymphoma is changing, and so keeping them up to date is also important here.
Yeah, I think that makes a lot of sense and a great pearl here. So, all right, moving on, I think, to the TAKE-AIM trial. I think you had shared some mutation profiles that were more favorably responsive or were associated with responses to the emma-ibrutinib combination. So there's a question about how TP53, the mutation that never seems to respond to anything, seemed to have a favorable response here. And any thoughts on that? Asking for a friend, too.
Yeah, I wish we knew. I think, again, this is one of those areas where I think we're just not that intelligent yet about why that's the case. And it's very interesting to me because, when I usually see TP53, I just, I'm not thrilled to see it, whether it's germline, certainly not germline, but also mutational. So I don't think we understand that, but I would point out that now that we are including this information in these studies, it's super important. I have really changed my own clinical practice lately, now with widespread availability of CSF NGS testing that has been evolving. it's really fun, again, nerd fun, but to send that off and look for mutations.
Yeah, I think, and to your point on TP53 mutation, I think there was sort of a discovery data set that was coming from that. So I don't think the take-home message was that TP53 responds to that. But I would say it's nice to see that TP53 mutations didn't universally fail on that therapy and provide some enthusiasm here. We don't need to be too scared of it necessarily. It's also, sometimes the devil's in the details too, and there's not every mutation of TP53 is necessarily inhibiting. And so it's possible that this was a mutation that maybe didn't. And again, it's a smaller data set, so I wouldn't leave here thinking about TP53 in primary CNS lymphoma. But I think just kind of exciting to just see that we can do this more regularly in trials and even in clinic too. So, all right. I think a couple of questions that have come through here on BTK inhibitors too, naturally, given the interest and excitement for how well these things work. So one question is just on managing these patients. So how often do you guys see infections in your patients with BTK inhibitors, particularly if they're on steroids as well? Is there any kind of supportive care or prophylaxis that you guys consider?
And that's a good question, of course, for the hematologists who know about the TED-ER study at the NIH, and of course, the initial risk of invasive aspergillosis infections that happened before antifungal therapy was included. It's a concern. However, for most patients who are on BTK inhibitors, we try not to overlap with steroids for too long. Now, this is where there has to be a happy medium. A lot of the BTK inhibitor combination studies, and which Dr. Sumrall presented the data for, the hidden piece is that the accrual in a lot of them was slow because some of the, at least the ibrutinib nivolumab study, which was done at MD Anderson, because one of the riders was to be off steroids prior to starting BTK inhibitors because of the fear of infections. However, of course, that leads to a lot of patients being excluded from the study. So what I like to do is to not introduce, if I'm using BTK inhibitors off-label, not on a trial as a single agent, I tend to overlap for perhaps no longer than 2 to 3 weeks on a BTK inhibitor, because if you look at the median time to response on single agent BTK inhibitors, you should ideally get to that at a with, of course, some cases might take longer, but ideally within 2 to 3 weeks, you should be getting some response and be able to taper off the steroids quickly to avoid the interactions with the antifungal agents. If for some reason a patient needs prolonged steroids, then yes, we would need to consider mold prophylaxis for these patients. It would not obviate some of the other BTK inhibitor infection risk, which is typically pneumonitis and just sort of a general immunocompromise, so to speak, but really you'd be taking care of the most worrisome infections if you anticipate an overlap that is lasting longer than 3 to 4 weeks.
So it sounds like if it's a BTK inhibitor monotherapy, not as concerned about the more serious immune-compromised infections. Certainly viral illnesses can happen as expected with the disease.
I would also add, when these patients, in their past, they've had rituximab, they've had methotrexate, they've been in and out of the hospital, and so if you transition to, this is a pill, there's a certain amount of education that goes with that as well. So oftentimes people think that pills are easier and less risk and all of this, and in some ways they are, but educating them appropriately, I think, and their family members is really key to managing it.
And I like to say that chemo-free doesn't mean side effect-free.
Yeah.
And, so that is, I think, that a key point to drill into them because, they think, non-chemo regimen, but, we know that that's not true.
Yeah, definitely. And just a pearl too, I think for people that are on steroids for an extended period of time and then you're adding in multi-agents, including BTK inhibitors, don't forget there can be a little bit of a drug-drug interaction that comes along with using those azoles and BTK inhibitors. So work with your pharmacists on trying to find the right dose balance between those things. So, okay. How about keeping on our BTK inhibitor focus right now, given all this encouraging new data that we're seeing with BTK inhibitors, are there any updates in any new clinical trials that came across in SNO or that has generated any excitement from any of you guys?
I would say just the ones that are highlighted, but there will be a new tirabrutinib study coming, so I'm kind of excited about that. I'm biased. I suspect that we will start to see this space open up more freely in the next few years.
Yeah, I think we see small, kind of these pilot studies, proof of concept studies that are coming with the novel BTK inhibitors, and it's really exciting to see. We're seeing orelabrutinib data, we're seeing tirabrutinib data, and even the other BTK inhibitors, zanubrutinib, for example, and stuff too. So I think this is an important class, and combining them in the next level is going to be really important too. Well, I think in a couple of slides, share the abstract for Dr. Susain, who's going to be presenting combination data with ibrutinib or lenalidomide in the front line in combined with chemotherapy. And I think that speaks to sort of the interest in generating combination therapies here. In a rare disease, we're trying to build up the patient numbers on these trials, but it's certainly a struggle to get the 500 patients that are enrolled here that we can see in large B-cell lymphoma or something.
Yeah.
So, okay, I think, let's see here. Okay, kind of another sort of management question now. In patients with refractory and relapse disease, particularly those with limited performance status, what factors guide your decision in salvage chemo versus trying to get people to auto stem cell transplant? The person that's relapsed, do you try to get them to a consolidation strategy? Do you make that decision up front, or how do you kind of navigate that challenge?
So that depends. So it's a great question. If a frail patient, and this is just simply my practice, right? Because again, as we talked about, there's no standard, so everybody's practicing in a certain fashion. But typically, for the older frail patients who have had relapse refractory disease, lately, I've been trying to prioritize consolidation, wrong word to use, but rather salvage and bridging in an attempt to get them to CAR T-cell therapy. So using the minimally toxic salvage to try and get them to an earlier CAR T would be my priority. So I assume that the patient in question has already received methotrexate-based chemotherapy and they have relapsed post that. I would not, and again, of course, if it's a super late relapse, you can use methotrexate-based agents as the salvage. But for me, what is the end game for that salvage is the key question. And for me, the end game for that salvage in an older frail patient lately is becoming CAR T-cell therapy rather than consideration of an auto transplant, which, of course, is a challenge because it's off-label. So it just requires effort from one side to provide documentation, letters of medical necessity, so on and so forth for that. And for a patient who I think is unfit for methotrexate, I would probably use perhaps a BTK inhibitor combination with IMiD, again, as a bridge, going on to CAR T-cell therapy, knowing that there are translational data showing that the IMiDs and the BTK inhibitors can also enhance T-cell efficacy and reduce T-cell exhaustion. So perhaps they can be an adequate bridge to getting to a T-cell engaging treatment. With data coming in from glofitamab, and I was at a meeting recently where where I was talking to some of our private practice, colleagues, and a couple of them have been able to, probably sheer luck on the patient's part, been able to get bispecifics approved for relapsed primary CNS lymphoma. Wow. So if that is the case, then again, use that in order to get to a consolidative T-cell engaging therapy would be my goal. And I was recently successful in getting Lysocell approved for a 51-year-old relapsed 2 years post methotrexate and auto transplant. So required 3 letters, but hey, a win is a win. So that would be my approach to this frail patient who has relapsed, likely post an initial methotrexate and possibly Ara-C rituximab-based treatment.
I'll take a little bit of a different angle. I've seen patients who come in with recurrence who we find it on imaging, surveillance imaging, and they're asymptomatic. That's one patient population. You have the others that come in sick to the hospital, and then sick could be a broad range. It really is so multidisciplinary in that setting. I'll take the more difficult patient of coming into the hospital, because then you really have to sit down and process goals with the patient and the family. And if someone is frail, you need to fully assess them. And there are some ways, we'll use some tools with our geriatric oncology colleagues, and also neuropsychology. So where are they cognitively, trying to figure out what their performance status was before recurrence. And the other thing that floats around in this space is radiation. And some centers are very quick to go to whole brain radiation. And so I think I will often refer to radiation. It's a gift for some conditions, but once you give it, you can't take it back. And you know that you will cause harm with that therapy. And it's very challenging once someone has been radiated, be it whole brain or fractionated. You have so many difficulties after. And a lot of people, I think, are still practicing where you will try a therapy and then move on to whole brain. Or some people are still using it as consolidation as well. So I think it really takes sitting down with the patient and their family. What age are they? What's their performance status? Are they frail? What are their goals? Do they want to go through a big treatment? Can they pull that off? Do they have family support? Do they have insurance coverage? So all of those things, are very important, including your social worker, nurse navigator, if you have those tools available too.
And that's a great point, Dr. Sumrall, because, and I wonder that now that it, again, sort of not to harp on T-cell engager therapies, but
we are at ASH.
But we are at ASH. So, but now that we have data of and abscopal is not the correct word to use, but I'll just use it as a effect that now we have data of radiation, post apheresis or sort of pre-CAR T infusion, which again, the goal is to expose more T-cell epitopes and have a better response. Perhaps there could be an exploration whether we don't need to do whole brain radiation, perhaps consider a stereotactic radiation if you're trying to pose T-cell, if you're trying to get to a T-cell engaging therapy and perhaps elicit a similar response as we see in systemic DLBCL. So perhaps that could be an area for exploration.
And it's interesting because depending on who you ask, you get such diverse opinions about it. And again, in a space where there's no standard and you can form an opinion literally about any of these therapies, it can make it very challenging. I'll also add to that, if you have a patient traveling to multiple centers for different opinions, boy, when they finish that journey, they're completely confused. So
they're a great trial candidate because they were able to make it to all those opinions and be in a good performance status, hopefully.
So, the ability to have these trials out there, which we didn't have before. And if you look, on the clinical trials website, they're open at multiple places across the country. We are truly in a space where we're learning more and treating people, which we were never in this space years ago.
I think those are excellent answers. I think this radiation question is really interesting. There's this newer data that's coming out on reduced doses of whole brain radiation possibly looking safer. That's certainly generated some enthusiasm in our clinic, potentially for those people that have relapsed a few times, that are young, that really want to get as many years out of their life as they can and are willing to take a shot like that. And so we've been a little bit encouraged by the efficacy and the much lower toxicity that's coming along with the reduced dose whole brain radiation. But kind of keeping our focus on the BTK inhibitors, a few more questions have come in here. One, just asking about BTK inhibitors in general, do either of you have a preferred BTK inhibitor? And any thoughts on the data surrounding blood-brain barrier penetration of these agents?
I do have a preferred BTK inhibitor. It's zanubrutinib usually, but actually tirabrutinib data has looked pretty great, especially in terms of cardiac toxicity. And not at SNO, but at ICML, the PRISM study was presented, which was a zanubrutinib data in CNS lymphoma. And of course, Dr. Naik presented, the tirabrutinib data. And perhaps, between the two, I mean, we don't have tirabrutinib approved, so it's a moot point. But between the two, tirabrutinib seemed to have a slightly longer, duration of response, as well as perhaps better responses in a more refractory population. So that might, if it's approved and available for use, might supplant zanubrutinib, in my opinion. Acala is fine. I just don't use it as much. And ibrutinib, while I will put a caveat that, a lot of our fears for using BTK inhibitors and their, cardiac or toxicities are really extrapolated from their use in indolent non-Hodgkin lymphoma, when the populations are vastly different, morbidly, because the primary CNS lymphoma people will simply not be on those drugs for as long as the indolent, non-Hodgkin lymphoma group. So I would use ibrutinib because that has the clearest dose-escalated CNS penetrant data, but frankly, I think zanubrutinib has, those data too, so that's what I prefer.
I think those are great points. I would say the one that you can get into the hands of the patient.
Exactly.
That's true.
We've had the most success with ibrutinib. I think your point about length on treatment and considering that is super important and worthy. I know I have not used Acala, but in talking to colleagues, there's quite a bit of headache there, which can be difficult for this patient population. I'm really biased because I've used Tira on study. I'm really enthusiastic about it.
I like that.
And again, being able to have choices is pretty exciting.
A lot of our patients on BTK inhibitors, it can be very difficult to take them off BTK inhibitors, in part because if they're dealing with a relapse refractory setting, sometimes they don't want to. They know that experience. Sometimes the oncologist doesn't want to either because they know what that experience looks like if you're risking a relapse. So I am excited about these sort of next generation BTK inhibitors, in part because their safety profile is a lot better, because sometimes what gives me a little bit of heartburn is that low but significant risk of cardiac toxicity that comes along with ibrutinib, particularly those ventricular arrhythmias. So it's really nice to have these options, and really nice to be having a BTK inhibitor that's like tirabrutinib that is being developed specifically in the CNS lymphoma landscape. So what about BTK inhibitors in combination with PD-1 inhibitors? There's these PD-1 inhibitor data sets that look so intriguing, and they hit on this really important immune evasion concept that comes in primary CNS lymphoma. What are your thoughts on combination strategies with PD-1 inhibitors?
I personally have had difficulty in this space because so many of my patients require steroids at time of recurrence. And it is hard to get them off of steroids to have a good, meaningful benefit with PD. So it makes sense. I think you have to be highly selective for that patient population.
I haven't been too excited about it. I mean, the initial encouraging responses came from very, very small data sets. And then I don't think that those responses have been able to be replicated in a larger, and larger means from 5 to 18. Really,
I was going to say the 5 patients.
So from 5 patients to 18, it's not been able to be replicated. So not too excited about the PD-1s in this combination with this space, but agree that BTK combinations are needed because monotherapy is not durable. So.
Yeah, I would agree. I mean, I think all of these parts are true. I think some of these stories about really wonderful responses to PD-1 inhibitors are true. And yet, when we study it in greater detail, sometimes we don't quite see the data we are hoping to see, that we think would make sense to see, understanding some of that immune evasion perspective. What's probably happening is heterogeneity, would be one guess, particularly maybe in the microenvironment. There's some data that will be presented at ASH here on some of those microenvironment parts of it that might matter. And maybe that's the difference here when we're seeing some responses with one agent but not another. And the struggle is real on managing a rare disease.
It's like any port in a storm, right? So if if that's the only thing you can get, and if that's you're left with and you get it, the patient responds, they respond, great.
Yeah, so I'd love to see more data in this. I'd love to see if we could ever reach that point where we can get sequencing quickly and identify tumor signatures quickly. You might be able to personalize the approach where you could combine PD-1 inhibitors with other ones depending on mutational profiles. So that's a great segue to my next question about how you guys look for MYD88 mutation tests. Do you do this in your newly diagnosed CNS lymphoma patients, and does that drive your decision making? For example, if you found that they were wild type, would that discourage your interest in a BTK inhibitor, or not enough data to say that yet?
I would say not enough data, but I feel like I have to share this story because it's exciting. I had a patient I recently saw, and we were trying to determine if he had lymphoma or something else. Ultimately had a brain biopsy, which was inconclusive, and then I sent off CSF testing, and he had a mid-88. And I danced down the hallway. I did, true story. And then I emailed everyone on the team, and I said, I think we just caught this lymphoma by CSF profiling, and I'm so thrilled. But then I said, well, now I don't know what I'm going to do with it. So it's fun to be in a space where we're learning more about how to detect things. Again, how quickly you can get that information back has been a rate limiting factor to influence. I've not used it to influence what type of treatment, but I do think we're getting closer to that.
I had a similar case where actually a couple of colleagues who are practicing in private practice, they emailed because they had a case where they did a biopsy, inconclusive, imaging looks like lymphoma, but the only thing that they found was MYD88 in the CSF, and it's like, should we just go ahead and treat as a lymphoma, as a primary CNS? And I think that it's still a difficult, like, you know, it's like difficult to just say, like, you know, let's go full steam ahead, but definitely given that it's probably present in closer to 70% of primary CNS lymphoma patients and not really seen in any of the other brain tumors,
That's
right?
That's exactly right.
Probably you could, you know, say, yes, let's go ahead and treat and see what happens.
It's a really interesting space, and it's really been unfolding over the last few months. And then you can also track variant allele frequency too. And so I think we're going to see more to come. But again, just emphasizing how far we're coming in this field that we even have the ability to have this discussion. And I'll also add, you'll notice oftentimes we'll say, I don't know. This is a great space for saying, I don't know, or this area needs exploration. More so than other diseases. We really do need to learn more in these settings.
How, speaking about detection and stuff, you mentioned some of the molecular analysis that is gaining some interest here. Has circulating tumor DNA or MRD guided strategies made your way into clinic yet? Are you testing for that in the CSF?
We've tried. There have been multiple companies. This is like the golden goose, right? And so there was a company that was offering this and went out of business during the pandemic. So I had high hopes for that. And now there are a couple that are using different strategies. So not so much, but some of the newer ways to profile, I think, have been a little bit better. Just on the screen, we also have role of neuroimaging, and I think that's important too. And when we're thinking about molecular analysis, I always put my imaging and my path, right beside each other.
Yeah, I think that makes a lot of sense. How do you follow sort of the standard guidelines on neuroimaging? Do you do 2 years and every 3 months? That tends to be our practice in the newly diagnosed setting, and then space it out. Do you follow a similar strategy, or do you stop imaging ever in these patients?
Makes me hurt. I'm an over-imager. My name is Ashley Summerall. I'm an over-imager. I like to over-image, but I do. In this disease, it's a little different than glioma. In glioma, we are definitely, every couple of months. I will space it out, and then I'll eventually do annually. And one of the reasons I do that is not to just look for recurrence, but to also look for white matter changes from methotrexate, because we have some people that in their T2 FLAIR images, they will develop these white matter changes with time. So I'm doing both of those together.
I think we've spent a fair portion talking about our treatment selection and how we can integrate these novel therapies, but maybe we could spend just a couple of minutes on sort of tips for optimizing collaborations. I know, Dr. Chauhan, you've had a good vision on how you'd like to grow this in your own situation.
And thank you, Dr. D'Angelo. And it's really just a vision. I think that the big problem with primary CNS lymphoma is it's the borderlands between neuro-oncology and hem-onc. So different institutions have entirely different practice patterns for even intake of these patients. So the previous institutions where I was practicing, the lymphoma group or the hem-onc group had, for lack of a better word, dibs on the primary CNS lymphoma, newly diagnosed cases or whatever. So you got them right at, you got them right at diagnosis, and then of course we collaborate with our neuro-oncology colleagues and move on forth. But at other institutions, neuro-oncology, takes care of primary CNS lymphoma, and they perhaps see medical oncology even later at relapse or for transplant or, now perhaps for CAR T-cell therapy. I do think that there shouldn't be either this or that approach. It should be a collaborative approach. It's just that which group is going to give up their space or their, share the chunk. But ideally, the way I envision primary CNS lymphoma clinics are what is already being done for breast cancer, thoracic oncology, and for brain tumor clinics in multiple places, where a patient comes in and they're actually able to see neuro-oncology and hem-onc, ideally at the same or at a concurrent visit. And depending on different places, again, at my prior institutions, I was a transplanter and the CAR T and the cellular therapist, right? But at MD Anderson, I can do CAR T, all of it, but I can't do the transplant part. So, so then you need somebody from the stem cell transplant team on board, radiation oncology, neurosurgery, even geri-onc, right, social work and all of that. And it's just that ideally we should have a intake process where the patients are able to see these people in a relatively short space of time within the same week, or ideally in the same space where, people are just coming in and out, and then all of us sit together, perhaps at the end of the day or the beginning of the week, and go over all these cases together in a tumor board. And that should be the ideal collaboration. The way I have, again, I've been new at MD Anderson, so it's really just the beginnings. What I do is that every new primary CNS lymphoma colleagues as primary CNS lymphoma patient as an informal start to a potential MDT clinic later on. I see a couple of my neuro-oncology colleagues who trained at Sloan Kettering and Columbia. So of course they worked with Christian Gromes and they saw a lot of primary CNS lymphoma, but at MD Anderson they're doing mostly gliomas. But I involve them and we try to set up an appointment either the same day in clinic or the next day. This is key because you need that neurological, you need that neurological assessment. You need their eyes on the brain MRI. We try to get them to see radonc and stem cell transplant on the same day. At a very limited level, I've identified certain people in each of these groups who we're sort of collaborating with on an informal level on an email chain, but I'm hoping that over the next few years, this actually leads to a formal clinic. And one big piece that we really should talk about when we talk about collaboration is collaborating with our private practice community providers. Regardless of whichever way you cut it, they are the ones who are going to be seeing the majority of all cancers, whatever it may be, even if it's primary CNS lymphoma, and maintaining good relations with them, making sure that you have space to discuss cases with them, even as a informal teleconsultation if they have a question about these cases, and have perhaps an expedited pipeline when a community provider reaches out to you with a newly diagnosed primary CNS lymphoma patient to get them into your clinic, which will be the best way to get them to clinical trials and have a collaboration with them. That is I think that is a key part of the collaboration that we should also talk about, not just intra-academic, but really academic and community, because community engaged research is how we will get the rare diseases into the clinical trials and into more mainstream.
I couldn't have said it better, I think. So we've certainly kind of incorporated a few different, in addressing these questions, on a few different challenges that happen in incorporating this data, incorporating combination therapy data, and managing some of the supportive care for this. With just 2.5 minutes left, I did want to share a couple of abstracts that I think speak to some of the questions that came up here. Never sleep on translational science, even if you're clinical, because some of this is how we learn how these therapies work better. And so there's a couple abstracts highlighting the role of the microenvironment, particularly this hot versus immune cold that might give you a better sense of PD-1 changes. This might be the microenvironment where PD-1 inhibitors work a little bit better. So if interested, take a look at those abstracts there. They're both presented on Saturday. There are clinical trials that are being updated here in CD19 CAR T-cell therapy for those that were interested in the CAR T parts of the talk. Also combination strategies. So this is a zanubrutinib, rituximab, and high-dose methotrexate in frontline therapy that had some really exciting overall response rates. There is a question on how we make our frontline therapies better if relapse refractory is so hard, and I agree with that 100%. I think we should do all of these things until we can cure it 100% of the time with no toxicity. And speaking to more on these clinical trials too, Dr. Susain will be presenting her study of lenalidomide and ibrutinib in association with rituximab and methotrexate as an induction regimen. Kind of highlights the benefits from both of those different combination approaches and highlighting the interest in incorporating combination therapy. I think as far as biomarkers and real-world data here too, this was a study highlighting how mid-treatment CSF, circulating tumor DNA, and MYD88 clearance can give you a sense and augment your imaging therapies, and you can, and certainly an emerging biomarker that I think will be of interest here. For those wondering about the frailty problem here, there's lessons learned from the ILSG 45 study as a poster session on how patient fitness informs dropout and how we need to think about this when we're developing clinical trials here. Finally, we spend most of our time talking about B-cell lymphomas, and that's correct in the majority of this, but there are these patients that have T-cell disease, and a really nice oral, multi-center, oral abstract retrospective study highlighting the experience in T-cell lymphomas, and I think really important data for how we treat these patients. So with less than 10 seconds here, I'd like to take some time here to thank all the organizers for putting together this wonderful session, and to my colleagues, Dr. Chaha and Dr. Sumaral, for really expert insight, as well as all of the questions that have come along here.